Now, in this section of Barrett's esophagus, we'll be studying about the complications of Barrett's esophagus, what ultimately occurs after the presence of Barrett's esophagus, what are the changes that occurs which causes the neoplasia, and what are the complications. So in this section, we'll be studying about the molecular biology of neoplasia. How does the neoplasia really occur within the Barrett's esophagus? And then we'll be studying about dysplasia. There are two different types of dysplasia. One is the low-grade dysplasia and the high-grade dysplasia. And then ultimately the incidence of cancer among the Barrett's esophagus patients. In the molecular biology of neoplasia, during carcinogenesis, the Barrett epithelial cells accumulate a series of genetic and epigenetic alterations that causes a core physiological attribute of malignancy. So you'd be thinking, what are these core attribute of malignancy? So these core cancer attributes are that the oncogenes, for example, if we talk about the oncogenes, the cyclins, the D1 and the KRAS, if they're increased, they cause the cell to self-sufficiency in growth signals. The increase in the transferrin growth factor and the increase in the epidermal growth factor receptors causes the cell to acquire this potential feature, which is called as the self-sufficiency in the growth signals. And then if there's the inactivation of the tumor suppressor genes, which is called as the P16, it causes the cells to be completely insensitive to the anti-growth signals. So if there are no signals of the anti-growth signals, then the cells keep on dividing and they keep on increasing in their sizes. And then the inactivation of the tumor suppressor gene, which is called as TP53. It causes the cells to evade apoptosis and to completely inhibit apoptosis. Apoptosis is a feature which causes the cells to undergo a suicidal death and to completely finish off. And then when there is the reactivation of telomerase, it causes the cell to have limitless replicative potential. This potential causes them to replicate even furthermore. And then these neoplasms, they acquire their blood supply by the increase of the vascular epidermal growth factor. When this epidermal growth factor is increased, they sustain angiogenesis and they have a very rich vascular supply within the tumor cells. And then lastly, the cadherin and catenin MMP expression. These protein, they help the cells to be tightly attached to one another. So if there's a decrease in the cadherin and catenin, these tumor cells, they separate from the normal cells and from the surrounding cells, and they have a more metastatic property. In this way, these tumor cells, they can invade through the other organs and they can invade and they can metastasize to different parts of the body. So there were two things that were proposed, that the tumor cells, they're supposed to have two major properties, physiological properties, which help them in growing even further and having a neoplastic activity. The first thing is that the cells, they can evade any sort of destruction with the help of immune cells, with the help of T lymphocytes, B lymphocytes, macrophages, and natural killer cells. And the second is that they have an increase in their energy metabolism, which help in supporting the tumor cells in having more proliferation of the tumor cells. So these tumor cells, they keep on proliferating because they have changed the energy metabolism and they have made it favorable according to their own circumstances, and thus the tumor cells, they proliferate. So you'd be thinking about molecular biology. The section we're talking about the aneuploidy. What does aneuploidy really mean? condition in which there is abnormal cellular DNA content, and the aneuploid cells are at increased risk for neoplastic progression. What occurs is that these core physiological attributes that I've talked about of malignancy, they undergo a genomic instability. So this genomic instability, when occurs, it manifests as losses or gains in the sections of the chromosomes. So section of the chromosome could be lost and could be gained, which causes an abnormal DNA to occur. So aneuploidy is when there is an abnormal cellular DNA content and the aneuploidal cells are at increased risk for the neoplastic progression. These are relatively very highly used biomarkers for the neoplastic progression in Barrett's esophagus. So the doctors and the pathologists, they take the help of this aneuploidy feature, which helps in marking that the patient is suffering from Barrett's esophagus. The researchers have proposed 3 different types of ways to detect aneuploidy in a cell. The first is the flow cytometry, and then the second is the fluorescence in situ hybridization, which is also known as FISH, and the automated image cytometry. The latter two, which is the fluorescence in situ and the hybridization, which is FISH, and automated image cytometry, they're more feasible in the clinical practice to diagnose a patient with any aneuploidy. Now, dysplasia. Dysplasia can be viewed as the histological expression of genetic alterations that favor any sort of unregulated cell growth. So, we can divide dysplasia into low-grade dysplasia and high-grade dysplasia, like I've mentioned before. And dysplasia typically occurs due to the cytological and architectural abnormalities within the cells. The nuclear changes, it could be the cell enlargement, and it could be due to hyperchromatism, it could be due to any sort of stratification and atypical mitosis that occurs. The second most important thing is the loss of the cytoplasmic maturation. The cytoplasm doesn't really mature. And then the crowding of tubules and villiform surfaces within the cell and within the cytoplasm. In this picture, we can see the healthy lining of the esophagus. And then when the acid refluxes into the esophagus, which causes Barrett's esophagus, the squamous epithelium is changed into the columnar epithelium. And then an early stage of metaplasia that occurs, and then this is metaplasia, and then ultimately any high-grade dysplasia, which is a completely unregulated cell growth. So dysplasia, when we see dysplasia through the endoscope, it has a very it often causes a very subtle or no endoscopic exam abnormality. And the endoscopists usually use a 4-quadrant biopsy sample system. And these days, the researchers, they are using various type of endoscopic techniques. These are very new endoscopic techniques that are being used. This includes chromoendoscopy. Chromoendoscopy uses a dye which helps in diagnosing dysplasia within the esophagus. The second is the autofluorescence endoscopy. The third is the magnification endoscopy, narrowband imaging, optical coherence tomography, Raman detection method, and confocal laser endomicroscopy. These are very of the new endoscopic investigations that are being used these days to determine dysplasia within esophagus. In this picture, as you can see, that this is the normal squamous epithelium of the esophagus, and then there's mild dysplasia in which there's slightly the abruption of columnar epithelium. And then this is the moderate dysplasia, and this is severe dysplasia where there's unregulated cell growth. Now, if we talk about the incidence of esophageal cancer, patients with Barrett's esophagus are very highly prone to develop any sort of esophageal cancer, which is the adenocarcinoma. So patients who ultimately have adenocarcinoma are almost 0.25% per year. The patients with low-grade dysplasia are at the rate of 4.3% per year, like I've mentioned before, and patients with high-grade dysplasia are at the rate, develop adenocarcinoma at the rate of 0.9% per year. And patients who are with high-grade dysplasia, cancer develop within the approximate 6% per year. They're the most prone patients to develop adenocarcinoma within the esophagus. So in this section, we have studied about the complications. We studied about the molecular biology of neoplasia. How does neoplasia really occur? What are the core physiological attributes of malignancy which help in the neoplastic development? And then we have studied about dysplasia. What are the two different types of dysplasia? Low-grade dysplasia, high-grade dysplasia. And then we've seen what are the newest techniques that the researchers have come up with to diagnose a patient with dysplasia. And then we studied about the incidence of cancer within normal patients, within patients with low-grade dysplasia, within patients of high-grade dysplasia of Barrett's esophagus. That's all from this topic. Please keep watching the other sections regarding Barrett's esophagus. Thank you for watching sqadia.com.